This presentation is about the MRI appearance in terms of contrast enhancement and diffusion MRI of brain metastases, depending on the treatment with ICI, which is a type of immunotherapy, and related to the amount of immune cell infiltration in histology. This article has been just recently published, and you can refer to the full article online. So immunotherapy in brain metastases has been increasingly used, and there is a phenomenon for which from before immunotherapy to after the tissue is treated with immunotherapy, the patient is treated with immunotherapy, you see like a increased invasion of immune cells within the tumor tissue, which is thought to be linked to anti-tumor response of the immune system, and therefore it should be a phenomenon that is linked with a better immune response to the tumor and overall immunotherapy efficacy. So it would be good to have a non-invasive biomarker to monitor this tissue phenomenon non-invasively. We started from an anecdotal case where we noticed that tissue prelevated from an area with high diffusion and very intense contrast enhancement was mainly inflammatory tissue with immune cell infiltration, whereas the solid component that is darker on T1 post-contrast and with more restricted diffusion was the actual tissue-tal metastatic tumor. So our hypothesis is, what if the areas with more immune cell infiltration have local inflammation with vascular permeability, and this is why we get more contrast enhancement and more elevated diffusion metrics. So we went back and looked at 125 lesions from 93 patients, and we saw whether their diffusion and contrast enhancement phenotypes correlated with whether they were exposed to immunotherapy or not. And then on a subset of these 23, we also had tissue from surgery, and we correlated with the presence of immune cell infiltration, CD45, within the tissue. What we did is we segmented the enhancing component of the brain metastasis, and we pulled diffusion and T1 subtraction values. T1 subtraction is a proxy for the intensity of contrast enhancement. And with these two values, you can build a bivariate scatter dot plot and see how many voxels have a combined high diffusion, high enhancement, or a combined low diffusion, low enhancement. So this is a representative case. It's marked red in this habitat segmentation. So it means it has prominently high diffusion, high enhancement. It was treated with ICI. And when looking at the tissue, we see a lot of immune cell infiltration. The immune cells are stained green, orange, and red in this case. Another opposite case, it's labeled blue because it is a combined low diffusion, low enhancing lesion for the most, and was never treated with immunotherapy and has very little immune cell infiltration on tissue. So when looking at the immunotherapy exposure, we see that cases exposed to immunotherapy have higher diffusion enhancement voxel fractions, whereas the opposite, they have lower diffusion enhancement, low diffusion, low enhancement voxel fractions. And this phenomenon is even much more prominent and clear when we isolate cases that were not exposed to corticosteroids. A more rigorous way statistically to test this is to build a linear mixed model that accounts for observations from the same patient and adjusts for prior treatments and primary tumor, so other covariates, while also looking into the interplay of corticosteroids. And by looking at this, we saw that immunotherapy exposure is a predictor of diffusion enhancement phenotypes only in cases that were not treated with corticosteroids, whereas in case of concomitant corticosteroid treatment, they were not a predictor. So corticosteroids kind of disturb this biomarker that we are looking into. In terms of tissue validation on a subset of patients, we were able to see that lesions with more pronounced tissue immune infiltration exhibit more voxels with high diffusion, high enhancement, whereas on the other hand, lesions with less pronounced tissue immune infiltration exhibit more voxels with low diffusion and low enhancement. So it looks like, and these are overall interpretation, immunotherapy induces immune infiltration with local inflammation, and this causes more vascular permeability, which makes sense because we are seeing more enhancement, so more extravasation of contrast agents and more ADC elevation due to vasogenic edema locally. The relevance is that we could use these MRI phenotypes to monitor the effects of immunotherapy in those cases. Of course, we need more studies that compare directly pre and post immunotherapy to see if we see these changes in whether or not they're predictive of long-term response.